Hey everyone, Tom and I are here at Your Amigos Live 2025, fourth annual. We're at the world famous Ryman Auditorium.
Great venue.
Old Church used to be the home of the Grand Ole Opry, which has since moved off-site. Now it's an amazing concert venue if you haven't been, my favorite place in the world. And in this video, we're going to talk about novel combinations or novel doublets and triplets and some data and press releases that have come out. We're going to start in the refractory space.
So this is clear cell kidney cancer in individuals who've been pre-treated with immune checkpoint inhibition and VEGF-targeted therapy. And the question is, what is the current standard of care? Well, currently we're just sequencing single-agent VEGF TKIs.
Generally.
The history of combining drugs in kidney cancer, particularly combining VEGF-targeted therapies together, hasn't been that successful. You led all those negative trials in my recollection. And the question now is, are we going to be able to change that? So the first place to start is with lenvatinib with everolimus.
Yeah.
We saw a randomized phase 2 at ESMO just recently, where actually from PFS and from a response perspective, it looked better than single agent cabo.
It did.
And so from that perspective, we have a combination. Now it's obviously it's mTOR plus VEGF TKI, but in the past, we've always really been focusing on PD-1 VEGF combinations.
Right.
So that's new and that looks active. But then about a week later, we saw a press release for belzutifan, which is a HIF inhibitor, in combination with lenvatinib, beating lenvatinib in heavily
beating
cabozantinib in heavily pre-treated patients. Now, there are some issues around component parts, because in an ideal world, you'd have lenvatinib alone. But actually, I don't think lenvatinib is more active than cabozantinib.
I don't know.
Oh,
I think that's an open question. I think when I saw the Lena versus Cabo, I think everolimus is minimally active. And so it made me think for the first time, maybe it is more active. I don't know.
Okay.
It's a hypothesis.
There was the randomized phase 2 of single agent lenvatinib versus everolimus in the pre-treated patients with the LEN-EV trial. And the LEN arm actually did quite well in that.
Yeah.
Too small to make any conclusions.
They're all small trials.
So we've got this environment, but there are other trials in that space as well.
Yes.
So there are other second generation HIF inhibitors. So we've got casdatifan plus cabozantinib versus cabozantinib alone.
PEAK-1 trial.
The PEAK-1 trial. So that's another study in that space. And so we're actually in a time now where we're moving quite quickly into combinations in heavily pre-treated patients, which we weren't at before. And that's exciting in kidney cancer. The question I've got for you is, how important is overall survival?
I think overall survival is important because if we're combining targeted therapy, my opinion would be that they're not curative. You might get a rare CR in these studies we've mentioned, maybe a rare CR, but not a lot.
Yeah.
So they're not curative. So it's disease control and toxicity. And I might put toxicity first for most patients. Some patients have bulky symptomatic disease. Absolutely. Right. They need combo, they need LEN-EV, whatever. But I think that's a more rare patient in my practice. Again, at an academic center, but more rare.
Let's move now to the frontline space, because Cristina Suarez at ESMO presented a frontline randomized phase 2 study with len-pem as the control arm that performed really well. But there were some investigator arms that actually also performed well.
Yeah, so this was Keymaker 03A, frontline clear cell kidney cancer, len-pem control versus one of 4 triplets. Len-pembro belzutifan, len-pembro CTLA-4 inhibition, len-pembro LAG-3, and then pembro belzu TIGIT. The most exciting, 2 things. Len-pembro did really well.
80% response rate.
Yeah, unbelievable, as you would expect. Len-pembro belzu didn't have a higher response rate. It was a bit lower, but the PFS was higher, hazard ratio like 0.5 or something. 60 to 80 patients, not huge, but, a big multi-center randomized, pretty decent. And that is one of the investigative arms of the 012 Merck frontline triplet study.
Tell me about the frontline triplet trial.
Phase 3, len-pembro control versus len-pembro belzu, len-pembro CTLA-4, large, well over 1,000, almost 2,000 patient study that's fully accrued. Basically the next phase 3, I think, to read out in frontline kidney cancer. And this was a signal that at least one of those arms could be positive. Now, the other arm in that trial, the CTLA-4 containing arm in the phase 3, in the phase 2 setting, didn't really perform that well, with the caveat that it's early. CTLA-4 is not an early acting response PFS kind of drug. It's not a tumor shrinkage kind of drug, as our friend David would say. It's a TFS long-term OS. And maybe
you have to be a believer, don't you? If the trial's negative and you say, but it doesn't matter because it's going to be positive. Well, you have to be a believer, Brian.
I'm just saying.
I think my friend Hans Hammer, he's a believer. Are you a believer?
I'm a partial believer.
Believer.
I'm just caveating. I'm caveating the endpoints that were reported.
Yeah.
Disappointing was the len-pembro LAG-3. I know you're a LAG-3 hater, so I'm sure you'll talk about it, but it underperformed in this trial. And then just to close it out, the pembro belzu TIGIT also looked the worst. because again, you don't have a TKI in that regimen, so the response rates were 40-some%.
So we've seen LAG3, we've seen TIGIT, we've seen CS1R, we've seen OX40, we've seen a second generation of what we hoped would be immune checkpoints would revolutionize the disease after the success with IPI and with PD-1. That's not happened because this isn't the only time that TIGIT and LAG3, which were our most promising drugs, has failed. It's failed with Zanza in a phase 2 study over the summer where the response rate for the triplet was lower. And we've also seen the triplet struggle with the Roche program. They've also done LAG3 and TIGIT. Is it time to let that go?
I'm still a partial believer.
Partial believer.
I'm a partial believer.
I really do.
I think building on an all-immune regimen.
Because I think you're going actively in the wrong direction.
I think building on an all-immune regimen could be a better strategy than throwing a TKI in there.
But we tried that, and it was the worst arm. The TIGIT, belzutifan, Pembro arm performed as well.
Okay.
Why? Yeah, so that worries me. I mean, fair enough.
Fair enough.
Okay.
I'm worried as well. I'm just telling you, I haven't given up all belief. Anyway, summary.
I have.
Doublets in the refractory setting, definite activity. I do think you need to see OS or some gaudy non-OS endpoints, triplets in the frontline setting, but clearly there's a new era of combination therapy in kidney cancer, even if it's with the drugs we have and perhaps not exciting new targets.
If triplets were going to work in the frontline setting, why was Cosmic 313 Ipi-Nivo Cabo negative?
Well, it's only one triplet. As you know, there's toxicity issues, that limited delivery of Ipi, etc. So, I don't know. And maybe all the triplets will be negative.
One swallow does not make a summer.
That's what I was going to say. Maybe it wasn't a Black Swan event. I was going to get Black Swan in there. But anyway, a new era of combination therapy in kidney cancer.
I've enjoyed this podcast.
It's not a podcast. It's a video.
I got that wrong.
Anyway, it's been exciting.